Now is our last speaker, Professor Govindan. You will notice in the program, actually, this is his third talk today. Professor is a world expert in lung cancer, medical oncologist, and from Washington University in the States.
Thank you. I'm reeling from the effects of jet lag. So I just want to talk about the role of immunotherapy in mesothelioma. And actually quite refreshing to hear the surgeons and our radiation oncologists speak in more restrained terms about the benefit of local therapy. It's somewhat ironic for a disease that is predominantly local, and it is unusual for a cancer to really cause morbidity and mortality by being purely a local disease. And here is where the frustration is because of the volume and the location. Our local modalities are really insufficient at the current time. And unfortunately, mesothelioma is not a disease where we have a number of oncogenic alterations that we can go after. So that leaves us with this only one option at the moment as we can think of, immunotherapy. So what data do we have with immune checkpoint inhibitors? And I'll just briefly review what we have, and I'll just mention a few ongoing studies. And tremelimumab, as many of you may know, is a CTLA-4 antagonist, and a couple of early studies had shown some promising results based on a small number of patients. As you can see here, the one-year survival rate of about 50% considered relatively promising in the setting of previously treated patients with mesothelioma who had received 1 to 2 lines of therapy. And so this was an important study that was done, a phase 2b randomized study, a fairly large study with 571 patients. They were randomized 2 to 1 with tremelimumab or placebo, and following initial therapy in the second or third line setting. And the primary overall endpoint, understandably, is overall survival, since we do not have other therapies for these patients. And unfortunately, the study did not show an improvement in overall survival, despite being in a third-line setting, second and third-line setting, and randomized against placebo. And the median overall survival was a disappointing 7 months across the board. And this is a very clear no. This is a pure CTLA-4 antagonist. Although I have to say, in this study, none of the subgroups showed any benefit here, as you can see here, of any meaningful thing. You can see that confidence intervals broad, overlapping 1, and it was clearly a negative study. And the question really is, does it have any activity against a tumor? And for that, you look at the progression-free survival. Once again, there is absolutely no difference between the two. And traditionally with immunotherapy studies, especially the immune checkpoint inhibitors, the progression-free survival, especially the median PFS, progression-free survival, is not always impressive, but it has an effect on the overall survival. Here it's about as negative as it gets in a very well-designed clinical trial. Although I have to say that tremelimumab has returned more negative studies than even ipilimumab. The issue really is that is the drug or the setting or the CTLA-4 a very legitimate endpoint here. And the side effects are very understandable. So what about PD-L1 inhibitor? And there are, again, small studies, and this is pembrolizumab in PD-L1 positive mesothelioma patients. As you know, pembrolizumab has been developed more or less in PD-L1 positive patients in pretty much all diseases. And this is no exception here. You can see that the overall response rate is about 28%, slightly better than what you had seen with tremelimumab, although these are small numbers, and nearly 60% had some tumor decrease, as you can see here. But this waterfall plot is somewhat modest compared to what you see with some other cancers. But certainly in a disease where we have limited options, it's worth looking at. Similar results have been seen with the nivolumab, a PD-1 antagonist as well. Again, the response rates in about 20-25% range, and a small number of patients with 18 patients here. And one important difference between this and the pembrolizumab is that unlike pembrolizumab, this is not PD-L1 expression selected. This is all comers. And so that's all for the PD-1 inhibitors. What about the PD-L1 inhibitor? And this is the example here of avelumab. And this is PD-L1 inhibitor in patients with mesothelioma. This is part of a large phase 1 program with expanded access for mesothelioma and slightly higher number of patients, 53 patients here, and a number of patients had more than 1 lines of therapy. As you can see here, 2/3 of them had more than 1 line of therapy. And the response rates was somewhat disappointing with 10%, but a reasonable number of patients had stable disease for some time with disease control rate of about 60%. And again, if you look at the spider plots, you can see most of them are stable or slight decrease and some increases as well. And the waterfall plots is a little less impressive than the PD-L1. This was not selected based on the PD-L1 expression either. And the treatment-related side effects are nothing unusual, something that we are very, very used to, the PD-L1 blockade. And the response rate in terms of PD-L1 expression, again, it doesn't seem like there's a huge difference here. And but some of the radiographic pictures are not are fairly impressive. Here you can see a nice decrease in the lesion that you can see over time with avelumab. And if you put everything in context, overall there have been about 120 patients or so treated with a disease control rate in the somewhere in the 50 to 70% range. But the median progression-free survival is fairly modest, and so that's what we have with single-agent therapies. And the question really is, what should we do with the combination? So you have to set this, of course, in the context of what we see with chemotherapy. And some of the responses that you see here are in the frontline setting, but the second and third line setting, the response rates to chemotherapy is often single digit. And one study that caught attention at the last ASCO meeting was the MAPS-2 trial, where patients were randomized to nivolumab, or a combination of nivolumab with ipilimumab. And these are patients who had had one previous line of therapy. And this is about 120 patient study, fairly well balanced between the two arms. And the side effects are predictably a little bit more with the nivo and ipi combination, and with three treatment-related deaths. And the side effects are once again as expected, with diarrhea and some skin rash. And if you look at the disease control rate, it is numerically higher with nivolumab, ipilimumab. I'm not personally very persuaded that these are very different between these things. Again, given that there are barely 50 patients in each arm. And if you look at the intensive treatment population where they got treatment, the difference is slightly higher with nivo-ipi, but I have to really confess that both look reasonably better than what we had seen with some of the other studies. But unless it's a randomized study, adequately powered, large number, with higher toxicities, we have to be careful before you jump and start giving it this combination to everybody. There have been some nice responses reported in the study. This is, again, remember, this is with nivo alone. You can see a very nice pleural rin disappearing here, and liver lesions improving quite nicely with, again, progression-free survival, a modest but slightly better than what we've seen in the past with overall survival. Probably the best we have seen with immune checkpoint inhibitors in the MAPS-2 study of all things that we have seen. And of course, patients who respond do better, and that this is not a surprise. And the top curve that you see here is those patients who had objective response compared to those who had progression. And this is actually a bit of a stating the well-known fact. And in fact, the less than impressive responses that we have seen so far with immune checkpoint inhibitors, considering the fact that it is still better than the others, it can partly be explained by the fact that this is a disease that is not really set up for immune response, at least checkpoint inhibitors. Number one, to start off, the mutation burden is very low. If you look at the mutation burden of tumors per megabase of the genome, and the mesothelioma is closer to acute myeloid leukemia than to lung cancer, and nearly about 6 to 7 times lower the mutation burden in mesothelioma compared to the tobacco-related lung cancer. So the less mutations, less neoantigens, the immune system does not see it as sufficiently foreign. So that's number one. That actually I think is a minor problem for mesothelioma. The major problem is if you really think about how the immune system recognizes a foreign antigen at every step of the way, from dendritic cell, from antigen recognition to dendritic cell presentation to T cell co-inhibitory molecules to absence of co-stimulatory molecules and other milieus, other alterations in the milieu that suppresses the immune response, including the higher levels of IL-10 and myeloid-derived suppressive factors, macrophage, M2 macrophages, all are tilted towards a non-immune responsive environment in mesothelioma. It's almost tailor-made for not responding to immune therapy. And there have been a number of papers that really show that there is a higher number of T regulatory cells and M2 macrophages in mesothelioma microenvironment. And also there is a higher level of VEGF expression that prevents the T cell migration into this. So all of them are, every step of the way, it's stacked against response to immune therapy. It's in fact fascinating to even see some responses here. And so that's something worth keeping in mind. In the interest of time, I'm not showing all those data, but I think I want to put this in perspective, starting with the low antigen burden to providing a milieu that is really suppressive for immune response. And the PD-L1 expression is, in a way, it's a minor problem, and so far we've not really shown a clear link direction between PD-L1 expression response to immune checkpoint inhibitors. The published data, limited though they are, suggests that the PD-L1 expression is higher in sarcomatoid type than in epithelial type. As you can see here, it's almost twice as much in the non-epithelial type than in the epithelial type, and PD-L1 expression has been linked independently to poor outcomes in general. And so the way we can improve this with considering combination therapies, and one combination therapy that is being tested is a large study, the Checkmate 743 study, which is randomizing patients to Nivo-EP or chemotherapy in the frontline setting in mesothelioma. That can give us a little bit of an indication of whether the combination I showed you is whether it's worth the toxicities and the response rates are higher, or the combination is better than pemetrexed-based combination. I think it's a tough bar, but I think in the right setting, it may be of much more valuable. And there's a lot of interest in looking at various combinations of immune checkpoint inhibitors using both agonist molecules and antagonist molecules, in a way producing more co-stimulatory molecules and avoiding other inhibitory molecules in a number of diseases, and where they all have mesothelioma expansion cohort, and hopefully we'll learn much more about the optimal combination when we learn more from this as we go along. And but one final point is that the real advance in cancer immunotherapy, or in general and mesothelioma in particular, would come from a better understanding of what is driving in each patient's tumor the cancer progression. In one patient, in a given patient, may be more M2 macrophages, and the other patient may be a combination of Tregs and macrophages. And so you may have to customize therapy based on the combination of the immune suppressive molecules that are present in the microenvironment. And there's a lot of interest in doing active immunotherapy of various sorts, and the CAR T cells are making major major progress in hematological malignancies. In solid tumor, it is always a concern that there is not one target that the tumor cells employ, and there can be bypass pathway activated even if you go after one chimeric receptor antigen, and also the axis is an issue. And mesothelin is a great target that is being pursued in mesothelioma for quite some time, and various forms of going after mesothelin, and there is mesothelin CAR research that's currently ongoing. So I think those give me hope more than merely rearranging the combination of chemotherapy or even immune checkpoint inhibitors. In the right setting, one may want to use some kind of a vaccination therapy approaches, low-dose cyclophosphamide, or ways to overcome the Tregs, or even using the other agonist or antagonist molecules along with other combination therapies. For now, it is a challenge because of the low mutation burden, and it is fair to say that CTLA-4 inhibitors by themselves may not be that active in mesothelioma, and I think it's right to say it's not active at the moment, as we know. And the PD-L1, PD-1 inhibitors are modestly active, and hopefully the combination therapies will get us somewhere. And I see some hope here, but it is guarded one, And hopefully in the next few years, we'll learn more about this. Thank you very much.
Thank you, Professor. Any urgent questions for any of the speakers?
Hales, can I just ask you about the SMART trial in Toronto where they do the radiation before the surgery? Adjuvant.
Just a general question. Do any of the oncologists or radiation oncologists or diagnosing physician have an opinion about what the surgeon should do to their patients? Will you have a biased opinion whether they should have an EPP or a PD?
You know, the challenging question is that do any of these surgical therapies make a difference, localized therapy? You know, it makes us all feel good that we're doing something, but do they really alter the course of the disease? In other words, our patients are going to be better off with just a diagnostic biopsy and then go with systemic therapy. And I honestly don't think our systemic therapies are great, but then which one is the lesser of the two evils? So my bias is to do less than more and accept the rare patient who has a very localized disease, who has got a perfect, great performance status, otherwise no serious comorbid conditions, who may be a candidate for, operative thing, but we rarely see those patients. But again, as I think you pointed out and others pointed out too, patient selection is the crucial thing. And applying this to everybody, I think, is a challenge. There are patients who it has to be very highly selected and carefully selected ones.
I think the other point is just the cost function of the improvement in OS. If a patient gets 8 additional months through going through an EPP, is that quality adjusted time valuable for the patient? And I think just involving them in the decision is important. That being said, I think of the 4 patients I see for scans twice a year that are greater than 5 years out with mesothelioma, and had we not taken a very aggressive approach, I'm confident they still wouldn't be with us. So there's a small subset that seem to be long-term survivors of this disease, and we have to make sure we're being thoughtful about those patients as well.
Can I ask Professor Govind? I mean, you come from from Washington, and it's a great thoracic surgical center. So what do your surgeons do? Alex Patterson or...
So you just dropped the ball in his court, yeah.
Actually, we are, Rafael Biano and Harvey Pass are good friends of mine. And we are at the other end of the spectrum. Alec Patterson, very well, a great thoracic surgeon, and his group, they're not very gung-ho about surgery. And we all probably drink this from the same Kool-Aid bottle. But we are not big fans of big operations. And in fact, we don't even do, except in a rare situation, we don't do EPPs, although Alec has done quite a few, but we are very selective about this. And even pleurectomies, so we are very selective about this.
And I'd just like to end this. I did my fellowship in Mayo Clinic in 1993, and a Supreme Court judge of Los Angeles had mesothelioma, and he flew all the way to the Mayo Clinic, so he wasn't sure what to do. And I was standing there in the consultation room. He came to see a very famous surgeon, Dr. Pereiro. So Dr. Pyro told him, go home and be happy. Maybe in 20 years of doing EPP, I think maybe he was right. You know, because nothing has changed in the last 20, 25 years. Because the various opinions was given, but then he just told him to go home and be happy. I think it's a very systemic disease. It's like small cell. So if you're going to operate on small cell, that's what you're going to get. Right? I think so. So I always remember that episode.
So, which is going to be my next question. I think most of us as surgeons are moving away from the scary operation of pneumonectomy. So how do you think we are going to train the next generation even to do a pneumonectomy, let alone an extrapleural pneumonectomy? Probably it may be reserved to some elements of thymoma or radical thymomectomy surgery. How do you think you're going to get the next generation?
It's going to be like mastectomy. Nobody does Holstad's mastectomy anymore because everybody does lumpectomy. So it's going to be like ground glass opacity. Radiation oncologists will be treating ground glass opacities, and there won't be any more surgeons. So some surgeries will just die a natural death. Like
wondering why you came for the course now?
I was just going to say very quickly, in the UK, the Mars 1 trial removed the EPP completely, so it is no longer done. And the Mars 2 trial is now open, which is looking at radical prorectomy with induction chemo versus induction chemo. So we have a slightly different level of optimism that maybe that might help answer the question. But like Professor Govindan, we have very good surgeons, and 4 of them sit in my MDT, but they are very reticent to consider that kind of operation.
Any questions from the...
Yeah, I'm not a surgeon, but I just have this question in my mind that when you say pneumonectomy is a bad surgery, is it in the context of mesothelioma only, or is it in context of like simple lung cancer as well, or other, like for example, patient having bronchiectasis in the lung, having the risk of spilling over the infection to the other lung, and that's why requiring pneumonectomy. Is pneumonectomy bad for everyone in a non-specific manner, or is it only bad in the context of mesothelioma?
The thing you're taught as a surgical resident, a pneumonectomy is another disease. So you cure the patient of the cancer, but they all have another disease. And as I showed you on the one at the time, the Koreans did a very good study. The patients are cured of lung cancer, but they die from the morbidity of pneumonectomy. They get infection in that one lung and they get deterioration of the thing. So pneumonectomy is a disease. So the trend in thoracic surgery is to do lung sparing surgery. So you either do or to detect cancers which are so early, where you do limited surgery. Because the pneumonectomy is a disease by itself. So you're curing one disease and you're creating another disease.
So as respiratory physicians, because sometimes we are the ones who see the patient first and then refer to the surgeon, and so far we have been like made to believe that pneumonectomy is something that is an option, and it's an easy option, can be done, and surgeons will deal with it and they will do it successfully, no problem. Just refer the patient. So are we like creating a headache for the surgeon then upstream by living in this belief that, oh, no problem, pneumonectomy is a good thing, just refer the patient to the surgeon? Or should we be reserved in talking to the patient up front so that to make it a bit easy for the surgeon downstream?
So pneumonectomy, I mean, there are cases where you have to do a pneumonectomy, I mean, like destroyed lung, the cancer is very bad, but pneumonectomy has become less because neoadjuvant therapy has become so good. Because cancers which used to need pneumonectomy, now with neoadjuvant therapy, you can just get away with, the tumor becomes smaller, and you just do a lobectomy and get away. And a lot of these advanced cancers don't die from local disease. 2/3 of them die from systemic disease. So you don't want to do a very big operation. So neoadjuvant chemo radiation has been so good now that we do less and less pneumonectomies. But there are cases where you have no choice. That's accepted.
Any other questions? So I think we had a great day today, Prof. Is it all right? Can I conclude? So we will conclude the session for today. Thank you very much. Thank you.